Thank you all so much for being available and to answer some of our questions, because we come from Virginia and no one really knows what CRPS is there. We educate more people there than anywhere, so today's been great. But my question is for the pharmacist. Is there truly a ketamine shortage? Because that's all we hear.
There was a ketamine shortage in the injectable, that is correct. And from there on, doctors have actually reached out to compounding pharmacists that are sterile. So if you reach out to a sterile compounding pharmacy, all right, what needs to happen is that the doctor will go in and actually write out your dosing. And from there on, they make up the vial that will be injected into the saline bag. So yes, there was a shortage. Does anybody know where drug shortages come from by any chance? No? Okay, so real quick, and I'm not trying to have an agenda, but if an insurance company does not get a rebate from a certain manufacturer, sometimes they take them off of the formulary. So what happens is, it's not there is a shortage in the actual chemical, but because they're no longer included on that formulary, all right, what happens is the manufacturer down manufactures their amounts. So in the end of the day, if that ever happens to you, reach out to a compounding pharmacy that's a sterile compounding pharmacy. Your doctor would write the prescription, and from there on, they can deliver it right there and then.
Keep it up there.
Sure.
You're going to have to work extra hard. Next question. Oh my God.
Dr. Wu, Dr. Getson recommended that even though I have full body CRPS, that to get in there right away, treat my eyes and do a block as far up the cervical as I can get done to try to help my eyes, CRPS, first foremost, right away. The only problem is, because of all the talk today, I don't think I clearly heard him on what kind of block I need. Could you explain that one? Is it a sympathetic nervous system block, or is it some other kind of block?
So it's hard to say. Ocular pain is one of the more difficult things to treat, even for interventional pain physicians. Some of my cancer patients, ocular pain is more treated with a pain pump with the catheter up really high at C2. I do not recommend doing it for non-cancer pain, aka CRPS patients, because one, the only medicine I can use this high up is fentanyl, which is a narcotic.
I'm sorry, opioids are off the table for me.
I know.
Yeah,
so
I can't have that at all.
There has been some anecdotal descriptions where there are like high cervical catheters placed for pain pumps. You place it at the base of the skull and you run low dose fentanyl, and it may cover ocular pain. Another possible innervation for this ocular pain could be stellate ganglion blocks, because stellate provides a lot of the sympathetic sensations to the face. I had a few cases where they, I guess there was a patient with migraines who actually went to get her supraorbital nerves cut, and ever since then they had CRPS-like features, burning allodynic pains, things like that. They responded to stellate ganglion blocks. So that would be a better alternative for you if you want to try it.
Thank you so much.
Does that kind of make sense so far?
Yes, I just needed a type, and he left the arena. Thank you.
Okay, got it.
Anyone on this side before it goes that side?
My question is for Scott. You go across the country, right? You're able to, can you hear me?
I can.
You are able to represent people not just here in Texas, but also in other states, correct?
Correct. I'm board certified in personal injury trial law here in Texas, but I do handle cases in other states. It just requires me to file a motion with the court in that state asking for permission, which is not difficult to do. So yes, I handle cases nationwide.
Okay,
Thank you.
Hi, on there you are. Sorry. On physical therapy, I've been going for like 15 months, and so one of the challenges that I come up against is that the therapist doesn't really understand physical therapy for CRPS, and so there comes a point when it's like, how do you push to do what you need to and stay within their realm of the physical therapy thinks that you have to have like a beginning and an end, and in CRPS there is no end. It's like forever, going on. So they have like a caseload that they're supposed to close, and you never close. So how do you get your would you have recommendations on how to get your physical therapist to like keep your case open?
So what I do is I try to tell the patient right off the bat, we're going to do anywhere from 4 to 8 week increments. So you can come in that first stage, okay? It's going to be a long-term process. It's going to be a journey. Some people have been coming on and off for 4 years, It's like when you're dealing with somebody with Parkinson's. You can never let them go, because if you let them go, they're not going to get out of that wheelchair again. So you check in with them every 6 months. So we use that same. A lot of what I'm doing is what we've done with every patient in every realm of PT, which is get them in, get them started, okay? That first 4 to 8 weeks is giving you the basics. Now, I can't just watch you do it, do the activities after that 8 weeks. There gets a point where, okay, let's work on this stuff, and then you can come back 8 to 12 weeks later or 8 to 12 months later. It really puts the ownership into the patient once, and that's what I was talking about right off the bat. You become the therapist, okay? One patient joked with me, oh gosh, 15 years ago, you're the only business that tries to put yourself out of business. And so that's the way the physical therapy philosophy goes. The problem is, how do you explain it to the patient? So the way you look at it is that we do the 8 week increment, take 8 weeks off, take 16 weeks off, and then we work on specific things each layer of therapy, okay? And that's done through when you look at pediatrics, whether they're getting neurological rehabilitation or CRPS, because it happens in that realm too. A lot of it is putting that little time frame on it, and the net effect is then, here's what I noticed, the reason why I put that 8 week time frame, because when we went into the 13 week time frame, they started to become dependent. I can't do this without you. No, you can do this. That's why it's physical therapy and not something else. So you can do it, but it's going to take time, and it's going to take you getting back into your life. And I had one patient, she says, I think the moment I quit was when I got better. I'm like, well, good, that works good too. So we want to encourage that freedom. Get back to your life. And so we have to do these things, whether we like them or not, because it's the normal, natural process of learning.
So the goal is to get out of the physical therapist's office and doing those same activities
You
at home.
become the therapist. You want to do the activity. Our goal is to get you to your activity. Until you redefine what the next activity is, then that goes on to that next stage. So it's stages, okay? It's like with anything,
Okay, thank you.
Teach me to fish rather than feed.
I'm not sure who this will go to, but I wanted to know how y'all felt about chiropractors, acupuncture, massage therapy, things of that nature.
So I'm playing Dr. Stetson and Wu at the same time, so I can answer that. Let's start with chiropractor. Chiropractor manipulations generally is not indicated in patients with hardware in their neck. Because hardware, if you manipulate too much, it may make things worse. I have seen that. I have not everybody, but I had one chiro manipulated somebody's neck, and they caused a spontaneous dural leak. And they had persistent headaches because their spinal fluid's leaking. I had some other chiros that manipulated and then caused somebody to have a stroke because they had a vertebral artery laceration. It's uncommon, but In CRPS patients, I rather prefer somebody like Michael to do isometric exercises. Isometric means graded, not forceful exercises to cause mobility to happen as opposed to chiro manipulations. And remember, CRPS is a neurological condition that is not related to necessarily nerve impingement, right? It's central sensitization and peripheral sensitization. There's nothing structurally, there may be nothing structurally wrong with the nerve themselves. It's just nerves are hypersensitive. They have nerve allergy, so to speak. So for me, personally, I feel like chiros are limited in patients like you guys, right? I send for chiro for patients who have herniated discs in their neck and their back, who have sciatica. That's fine because you're actually decompressing the spinal column to reduce the pressure on the nerves. They do get some relief, but I get really, really nervous when my CRPS patients go for chiro because of the complications I have seen before, and it just doesn't make any logical sense to me in the population like in you guys. Does that kind of make sense so far? Acupuncture. I absolutely think acupuncture could be beneficial in CRPS. Acupuncture has been shown in studies to increase endorphins in your brain. So endorphins is what Ms. Martinez says. It's one of the natural opioid in your body that releases after releasing dopamine, so or pleasure hormone or whatever you want to call it. Endorphins will reduce pain. It's kind of like saying I'm going to use normal opioids that my body can make to treat my own pain. So acupressure or acupoints have been shown to sort of increase that endorphin level. So absolutely, I think there's benefit on early CRPS. I think it has benefit on late CRPS because the endorphins are produced centrally, right? So you not only modulate the central nervous system, but there may be some peripheral modulation as well. So yes, I absolutely think acupuncture or Eastern medicine, alternative medicine have a role in management in cases like you guys. Wendy, what was the other thing? Massage therapy. Absolutely. So massage causes, I personally think massage therapy is very beneficial, and Mike, feel free to chime in. Massage therapy increases muscle blood flow. Okay, when you have more blood flow, the tissue becomes more malleable, so you can stretch more, you can load more things. Is that a correct statement, or am I overly simplifying?
Massage therapy can be very beneficial because it's sensory stimulation. Okay, so if we have an aversion or our cortex isn't getting that signal, massage can be good. There's a lot of people. It's hard to ever speak for any other profession. So like I could say, oh, massage is great, but is everybody going to do it the same way? That's the uniqueness of that. But like I said, when it comes to the myofascial, we really need to look at it with a lighter touch, not a heavy touch. And so when they're doing deep tissue because they think it's best for you, I remember one time I got a massage. Oh, you're an athlete. I'm going to go deep. And then it's like, no, that hurt my groin, And so we don't need that, What we need is that TLC, when the purpose of the massage is to get you to go into that relaxed state so the body can heal itself. It goes right into Still's philosophy, is that the body can heal itself. We got to give it that environment. So there are times where we need the input, the sensory input. And the lighter the better because it moves lymphatics, okay, which is, when you go into dysautonomia, that's huge with it's one of those little factors that makes that heart rate race, is we got byproduct just sitting on the tissue. So we got to move the byproduct off the tissue. And so if you find somebody who really knows what they're doing, and it's just, same with physical therapy, if they're listening to you and being careful not to hurt you, then it's good. And that's going to be with everything. They got to listen and be careful.
That's easy, too easy for him.
I have CRPS in my right knee, and I also have other issues, just regular orthopedic issues. This is for anyone who can answer. I'm having issues finding an orthopedist that knows enough about CRPS to know not to have me ice it. So do y'all have any recommendations for finding a doctor that knows enough about CRPS actually help without making it worse, rather than somebody that's just read a page in a textbook 20 years ago?
That's a very, very hard thing to answer. I think it's very orthopedic surgeon dependent. Now, I also want to ask you this. Is your CRPS pain worse than your orthopedic pain, or do you have orthopedic instability causing pain that is overriding your CRPS?
I have orthopedic pain that's overriding.
So if there's orthopedic things that's overriding CRPS, you still treat it like any orthopedic patient. You just have to be careful not to make CRPS worse. So what I do is, I start with conservative management, put people on some non-opioids first. I try ketamine cream. Heating modalities is more helpful than ice in general, okay? So for chronic pain syndromes, I do not use ice that much at all. I use more heat because you want to make more regional blood flow. You want a tissue to be more malleable, so I use heat more. I usually do topical compounding. I can call my compounding pharmacist, said, hey, this is a nice thing I wanted to do for the patient. Can you make this and that? And I make it, I work it in and see if you can rehab, sort of conservative management with isometric exercise to rehab through it to cause stability, right? Orthopedic pain is structural in nature. Just like when you have osteoarthritis, the knee, it's because the knee joints are grinding on each other and you're feeling the nociception. So joint stability is very, very important. So when you do exercise or isometric stuff around the knee, you stabilize the joint first. If it doesn't work, then you can try interventions like injections, but again, got to be careful on the CRPS knee, or you can go for orthopedic repair. Now, I agree with Dr. Stetson. When you go for orthopedic repair, you better damn sure you really wanted it because you have a chance to flare up your CRPS. But I was telling Alice, don't let CRPS be a detractor to fix something structural if you need it to be fixed. If you don't have an ACL and you have an MCL tear and your knee is unstable, you can do all the physical therapy you want. If it's truly surgically unstable, your knee will buckle, you will hurt. You will need to have it surgically repaired. I recommend finding a orthopedic surgeon that at least have some understanding of CRPS and find a good anesthesiologist to take care of you during surgery. I cannot stress that enough. Good perioperative anesthetic care can prevent CRPS from flaring up. In fact, some of my patients who actually had knee surgeries done, what I recommend to the anesthesiologists at UT, because I was a previous UT faculty, I would call them up and say, listen, this is a CRPS patient of mine. Can you do me a favor and run intraoperative ketamine? I absolutely agree with Dr. Stetson that intraoperative ketamine does prevent central sensitization re-injury. And if you can, do an epidural catheter, okay? So remember the epidural catheter for short-term infusion I mentioned? I think they're wonderful in patients who have CRPS who's undergoing perioperative care because you want to prevent your body from sensing the trauma, the injury, the peripheral sensitization. The ketamine, I think, will help prevent the spinal cord and brain from seeing it, therefore preventing, central sensitization. So with that combination, I think I had CRPS patient that went through surgery without flaring it up and things like that. Even if it flares up, post-rehab, because I have some patients that got repaired that, their CRPS flared up, sympathetic blocks will do the trick usually. 1 or 2, with or without ketamine infusions, can generally put you guys into remission.
So just finding a doctor, it's kind of just go to a doctor and see what they say about CRPS and then just go on to the next doctor and keep going until I find one?
You need at least an orthopedic surgeon or any surgeon to have some understanding of what CRPS is.
How do you find somebody that has experience?
Where do you live?
About an hour south of Houston.
Okay, so I would start with support groups, Facebook groups. If you wanted to give me an email, I'll put it on our Facebook page. That might be a good way. Word of mouth is the best thing. We don't know.
So one last thing with the knee pain and the CRPS with the knee, when we're looking at the knee being the issue, we got to, again, the round the dragon approach, we're not going to go after the knee. We got to go after the foot. We got to go after the hip. And the hip, of course, is connected to the sacrum, and sacrum is connected to the lumbar, et cetera. It just keeps going. But what I find with any kind of CRPS for the knee, I'm going to go right to the foot right off the bat. I'm going to free up with strain, counter strain to the foot. I'm going to take them in. I got to show the brain the range of motion of what is there. And then we can incorporate into some sensory integration type of movements where we're functionally using that foot for purposes other than exercise, but in the same sense we're getting the exercise. So we go foot, and then we look at the sacroiliac and hip, and we get those functioning properly, and then we start seeing the knee, because its relationships with its synergies between the foot, he's talking about Mortons Neuroma. That Mortons Neuroma, there's so many times it's either that the pattern will be the Mortons Neuroma or the patellofemoral pain. It's a one or the other. They're from being too on your toes too much. And then you go see at the soccer practices, the coaches teaching them to run on their toes. When it's like, then they'll get to college and they're going to learn how to do it all a whole different way of running. So it's complex, but it's finding a good physical therapist who understands the dynamics of the closed kinetic chain.
I was going to augment what you were talking about, that basically you have biomechanical, biochemical, and structural problems. CRPS has all three of those going at the same time. So if the knee's involved, then immediately you would need to roll out condylation of the patella due to pronation of the foot, causing the patella to no longer be sliding up and down in the valley. I've seen lots and lots of patients that's been it. To finish up on the Mortons Neuroma, you always need to rule out tarsal tunnel syndrome. They look the same, and if you just pump up the blood pressure cuff on the ankle up above the arterial pressure at the ankle, run it up above 145. They're going to have a Turk's test if there's a tarsal tunnel syndrome there. Rule that out.
Dr. Rhodes, we just say 2 minutes about who you are and what you do.
I have the unique situation of having complex regional pain syndrome and being a physician at the same time. I've seen more than 2,000 people. I'm in the Woodlands here. You're in my neighborhood. And I do all electrostim, no shots, no pills. I get everybody off narcotics, off gabapentin. Lyrica, the whole enchilada, and just a completely different way. And I do thermography. So, I mean, y'all have been talking my language all day. All thermography, I do heart rate variability studies, vibration perception threshold with the bioanesthesiometer, showing the degradation of the proprioceptive nerves. And the proprioceptive nerves come back in 5 days. Patients come to see me in 5 days. Literally everybody is better within 5 days. Sleep is usually the first thing that comes back. Energy comes back. Sleep is absolutely necessary because you heal when you sleep. And 50% of the people I saw, and I've seen more than 2,000 people with this problem in the last 27 years. Last year, more than 50% of the people were better day 2.
Thank you.
Thank you.
He has a pamphlet that was on the registration table. Couple more questions. He's getting his exercise, isn't he?
Going to try out for the Astros next year.
Hi, this is for Scott, not necessarily a question, but kind of going back to your talk before. In my previous work comp case in Kansas, even before I filed a case, part of what my team of doctors wanted to see, in addition to the Budapest criteria, was with my stellate ganglion blocks, they wanted to see the progression like Dr. Wu described with as a diagnostic criteria, successful blocks, and then a time period in between, and then some more blocks, and then the longer period, and so forth. And sorry, I get a little shaky. I ended up with 20 blocks before we actually went, okay, they work and I'm getting more longevity, but this is not a long-term management. But anyway, that was one of the things that actually helped my case, was that that team used that as a diagnostic criteria. And I didn't know if that was something that you had used before, if that would be helpful as far as your cases.
It has been. I guess what I would say is, for me, or from my standpoint, you've probably heard the saying of, if you've seen one brain injury, you've seen one brain injury. I think CRPS is similar. You've seen one case of CRPS, you've seen one case. When you say that your doctors wanted to see this or that, you mean the workers' comp doctors?
Correct.
Okay, so first and foremost, I wouldn't consider those your doctors.
Yes.
Yeah.
At the time I did, because I was very naive, and
Right.
I worked at a hospital, and these were the doctors at the hospital as well. So they're, not to get political or anything, but there was also some conflict of interest because of how the system was set up within the hospital and within the work comp and all of these things, but also being aware that this was the best pain management team for me in that area. So give and take, compromises, you know.
Yeah, I think, at least from what I see in the legal arena is, number one, it's a clinical diagnosis, so it helps for the doctor to actually see you. It's a diagnosis of exclusion, and so they want to run certain tests, and so you might have a lot of negative tests, and that's part of that differential diagnosis, the ruling things out. But at the same time, there's no one test to say, yes, you have CRPS. And so I think there's a different, every doctor's different. Some want to see these 3 things. Some want to see, those 5 things. And I can't help but to think, okay, well, when you say my doctors, my inclination is to say, well, if they're workers' comp doctors, they're probably going to want to see as much as they can in order for them to consider denying you. That's just my experience. I hope
Certainly one of them was, the other wasn't, and so there was conflict between the 2 doctors as well.
So I guess what I'm saying is my experience is that I think if it wasn't a workers' comp situation, you went to a regular physician under health insurance, my guess is they wouldn't need to see 100 different things to qualify you for. Every doctor has their own level of tolerance, and I'm thinking that the workers' comp doctors are probably looking for ways not to approve you. So I don't know if that answers your question, but that's been my experience, and I appreciate your question.
Sure, thank you.
I'll do the last one. I'll go. Before we end, we have one more last question. I just want to thank you for coming, and also thank our tremendous faculty today. It's been really great. Who's got the last question? Okay.
I have a question.
Manny.
Yes, please.
Got one right here.
I'm sorry, thank you. How many of you guys have actually tried CBD and failed?
Say again?
How many people here in the room has tried CBD and failed? I'm sorry, I didn't get a chance to give CBD its due diligence, but we had failure with CBD.
Well, it helped with my hands when you put the lotion.
Oh,
I
yeah.
used to try the oral and it did not work.
Let's focus on the oral. I don't actually want to focus on the lotion, but thank you for that. I'm happy that it did help. Go ahead, my lead. Okay, the 2 things that I didn't get a chance to say, and I need you guys to take this back. Okay, by the way, I am stationed in Florida. When a pharmacy is in another state than yours, it needs to be licensed in your state to serve you. So you cannot be my customers per se from wherever you guys come from around the US. But something that I want you guys to take back. CBD is not as needed I'm going to say this twice. CBD is not as needed. The more that you take CBD, the better that it works. When we put somebody in CBD, I follow up with them 3 times on day 1, day 3, and day 7 to make sure that we have the correct dose, that we're getting the correct response. You take CBD every day, just like it is a vitamin. Last thing I'm going to leave you with, when you put CBD under your tongue, and this is a pharmaceutical part, when you put something under your tongue, it crosses something called the first pass effect. So it gets faster into your bloodstream, right? It gets cleared less out of your liver, but from there on, it's a direct collision course with your liver. So that half-life that we spoke about gets cut. So it doesn't last long. And thus, you only use CBD under your tongue when you need relief from some anxiety or some pain right there and then. But for you to get a good effect from CBD, you take it every day orally, preferably twice a day. Okay? And that way you guys can actually get good success out of CBD. But you take it just under your tongue once or twice and say, hey, you know what, I didn't feel much difference, you're not going to get much difference. You just wasted 50, 60, and $100. Yes? Oh, drug interactions. It's very good that we mentioned that. I'm really sorry. For the doctors and the clinicians and you guys too, CBD is a CYP3A4 inhibitor. I want you guys to remember that CYP3A4 inhibitor. It has some inhibition also for 2C19, but 3A4 is the biggest deal. So if you guys are on warfarin, anybody here that's on warfarin, oxcarbazepine, carbamazepine, Keppra, Dilantin, yes. If you have any seizure medications, I beg you, go to your pharmacist who has no clue and tell them, hey, any of these guys is a 3A4 substrate. Okay, and he will run the interactions. Again, CYP3A4. When I put somebody on CBD and they have warfarin, I send them to get a basal INR and we monitor their INR because it will raise. So if they were hanging already around the 2.9, a 3.0, I wouldn't start them. I turn them away up until we can control the INR down between 2.5 and 3. I'm happy. I can see that. That's reasonable. But don't ever buy CBD out of a vape shop without consulting your doctor or a pharmacist that knows what's going on. Questions? Sure. Very good. So what we have found successful in our practice is we started patients on 50 milligram twice a day for 5 days. And I'm talking isolates, by the way. Isolates, again, because I didn't want any of my patients to actually show positive in their drug tests. So because of that, we used 50 milligram twice a day, 5 days. All right, and then we tried to drop them down to 50 milligram once a day. Reason being, CBD has a half-life of 9 hours orally. So what I usually have seen anti-inflammatory effect is 20 milligram twice a day or 50 milligram once daily. All right, otherwise, when I see 2, 3, 5 milligrams, 10 milligrams, I don't really see much anti-inflammatory effect, especially from isolates. Remember, isolates is just CBD on its own. So what I do with my patients, I do 50 milligram twice a day, 5 days. I follow up on day 1, make sure that we don't have any side effects, any dizziness or so. Day 3, they've been on 3 days of twice a day dosing of 50 milligrams, so they should be starting to feel what they're getting out of CBD. Day 7 is the 3rd day they have dropped on their lower dosage, and at that point they tell me, you know what, Manny, I was happy on twice a day. I think 100 milligrams is for me. Or they tell me, you know what, no change, I'm doing good, and the few that we had in the bank from the first 5 days are doing my job goodwill. And then from there on, we just maintain them on once a day. All right, but you undershoot CBD, you just wasted your money. You take your CBD as needed, you just wasted your money. More questions about CBD?
Maria, who are you?
Yes.
Sorry.
By the way, Maria is my wife. She is a biochemist, and she started our compounding lab. Yes, and then from there on, we actually hired a compounding pharmacist, and then from there on, we did expand. Yes.
Exactly.
Please, if CBD is an oil, All right, they cannot tell how much you're gonna take, so they have to disclose what's in the whole bottle. So when you see a 1,500 milligram bottle, that's what's in the whole bottle. That's not your single dose. Now, usually people try to mess with you where they go in and tell you, oh, but you're getting 1,500 milligrams and I'm giving you 2 ounces. They just added more oil to it. But in the end of the day, you just got 1,500 milligrams. So don't make anybody mess with you with the amount of ounces or milliliters. It's how many milligrams you got and what dose are you trying to reach. All right? If it comes in capsules, yes, they can say you have 30 capsules that are 50 milligrams each. And they would say that's a 1,500 milligram bottle. And they can say it's CBD 50 milligram per cap. Questions about CBD, please?
You mentioned, coming into warfare, there are many herbs that have blood-thinning properties, being primrose oil, artichoke capsules, turmeric, just to name a few. What about using those with CBD?
Not a problem.
What is that?
Restate the question.
Sure. So restating the question, there is some stuff that can actually have blood-thinning properties. I'm not worried about these guys, and I'll tell you why. What I'm worried about is this CYP3A4 substrates that the CBD competes with that will make more active. So CBD inhibits the CYP3A4, although mild to moderate depending on the medicine, okay, but it does saturate some of it. All right, meaning if I'm worried about warfarin, warfarin is already acting in order to thin your blood. All right, if I saturate warfarin, all right, it goes in and actually thins your blood even more. And the good thing with warfarin, it's an old dog that can learn a new trick. So I worked with many Coumadin clinics with CBD where they go in and then we start and then we literally see it go 2.5, 2.6, 2.7 and then teeters around there. And then from there on, it goes in and fixes back to 2.6. And I'm happy. All right, but if I'm already working at a very narrow therapeutic, going at 3, 3.1, yeah, we are in trouble. But other medicines overall that might cause some blood thinning, I'm not really worried about. But a blood thinner, yeah, I am worried about.